good morning to those of you attending from the United States, and good afternoon to those of you attending from the United Kingdom. Thank you for joining the CMS Measures Forum. My name is Martin Alvarado, and I am with Battelle. Today's presentation is titled Population Health Planning and Chronic Disease, considering the impact of applying a capitated budget for people living with multimorbidity in the National Healthcare System of England, commonly referred to as NHS England. And we will be presented by NHS England. Just a few administrative notes. Today's meeting is being recorded. After the meeting, we will send out an email with information about where you can find the slides and recording of this presentation. These will be muted upon entry to the meeting today. We will unmute for the question and answer period at the end of the session. Throughout the presentation, you can use the question and answer feature of WebEx to submit questions. With that, I have to turn it over to Dr. Jacquie Ling from the Center for Clinical Standards and Quality.
Hi, good evening all, and I'm actually really delighted to welcome Jacquie and Claire to the call and to have them share their work in such an important area. By way of background, as you know, the agency is really driving towards better care, better health, and smarter spending. And as an agency that touches on the lives of 1 in 3 Americans, we actually are very aware that the complexity of the population that we are privileged to be caring for and contributing to the care for is actually becoming increasingly complex, given the number of chronic conditions and the complexity that brings, and the increased risk that age brings to cognitive impairment and dementia development and progression, and also behavioral health needs of the population. So we have an enormous challenge in the actual tracking of data identifying populations, not just at that have current conditions, but also are at risk of developing those multiple chronic conditions and functional limitations that brings. So with that as background, we took notice of the work that our colleagues across the pond have been engaged in for quite some time. Really a data standpoint, describing populations and all that goes with it. So I'm really honored to welcome Jacquie White and Claire Cordeaux, and thank you both for being with us today. My sincere personal thanks. And that I'll turn it over to Marcia Smith for more formal introductions.
Thank you, Sherry. The Year of Long-Term Conditions Program, the National Health Service in England took on the challenge to implement a comprehensive person-centered approach to support people with multiple long-term conditions. And it set out to change the language of healthcare to develop a new way of thinking about planning services for people with long-term conditions. The aim was to talk about people, not patients, and conditions and not disease. The aim is to not separate physical, mental, and social needs of people, but for coordination of care in all of these areas. Support for the
Yes.
Okay, I got a message that I was muted. Okay. So healthcare provided support by developing simulation, which was developed to help inform and to describe how healthcare communities across the NHS are implementing this program so that communities with fast followers to the early implementers learn from those experiences and test the impact of the approach in their own area. This and other measures forum will provide participants with a review of NHS and England's experience with applying new models of person-centered care to people with long-term conditions, as well as demonstration of the use of simulation to test the impact of these models. Our speakers today are Jacquie White and Claire Cordeaux. Jacquie is NHS England's Deputy Director for long-term conditions and is responsible for improving the quality of life for people with long-term conditions, older people, and those at end of life. That has over 15 years experience working in and supporting health and social care teams to improve the quality of services for the populations they serve. Jacquie worked across the public sector at a local, regional, and national level, support teams to integrate care across organizational boundaries. Jacquie developed and led National Transformation Program, which includes the development of the Long-Term Conditions Year of Care Commissioning Program. Our second presenter will be Claire Cordeaux. Claire is Global Director of Healthcare at Simulate Corporation, leading an international team to improve healthcare using simulation all over the world. Claire's 30-year career covers community work, workforce development, health strategy, research, and innovation at national, regional, and local levels in the UK, NHS, social care and education, local government, the sector, NHS Trust, regional health authorities, and NHS Institute for Innovation and Improvement. Claire was one of the original developers of a population health-driven simulation tool called Scenario Generator, which is now licensed to Simulate Corporation and is used in 4 continents. Claire is about improving healthcare through the use of simulation and modeling and supporting others to do so. Recent successes include working with the NHS Long-Term Conditions Year of Care team to simulate the new models of care, testing the impact of improved services outside hospital on emergency room attendees and admission and bed capacity management solutions. Please join me in welcoming Claire. Again, our first presenter will be Jacquie White. I'll turn to Jacquie.
Thank you much, Marsha. And thank you very much for inviting us to speak today. It's a real privilege to be. Can I just check, given I'm not on the WebEx, that you can hear me just before I continue?
Yes.
I hear you.
Yep, great, thank you. As Marsha just described, what we wanted to do is share with you our learning so far. By no stretch are we suggesting we've solved it, and it would be fantastic to equally learn from others who are participating this afternoon, your own experiences. We've been working on the long-term conditions commissioning program for 4 years, and it was an experiment that came about from on the ground telling us that the biggest thing that was getting in the way of integrating care properly around the person, around their needs, was the funding flows that we had, the different contracts, the different performance metrics that individual organisations were all having to report on. So essentially how we as purchasers of care were setting up those contracts with individual providers was getting in the way of them being able to work together to support people. So the program came about to test what solutions we could come up with that gave us a place-based approach to using pooled, capitated budgets for a year of care, proactive, preventative approach to delivering the needs of individual people. The presentation today, we will cover a lot of the work that we did on understanding the population. There will be some of the data that we had to get a true understanding of the needs and how we identify people earlier and to support needs better. What sort of changes made in terms of the service delivery models, the capitated budget approach, as well as contracts, and importantly how we've used simulation throughout the whole of the programme to help us understand at a national level as well as the local teams that have been involved what impact any sort of changes, any sorts of decisions will make before they're actually implemented. So for simulation and modelling has been really important for the programme and continues to be really important for the teams going forward, continuing to implement their own delivery models. So just a quick background, if we can move on to the slide about who we are, please, Martin. So contextually, NHS, as you all know, established nearly 70 years ago and is still free at the point of delivery with exceptions around prescriptions, etc. But pretty much the whole of our healthcare service is still free. In 2013, NHS England was established, and its aim was to support or is to support local health systems working together with social care partners, so as a whole place approach to care to improve the quality of services for all, but also still to purchase some services. So NHS England is still the purchaser currently of primary care, our GP practices, our pharmacists, etc., and also our specialist services, the very high cost, low volume, rare procedures, etc. So we still do actually buy some services ourselves for England. The population that we serve, 53 million. We see 1 million patients every 36 hours, so significant demands on the NHS and increasing, and I'm sure that resonates with your own local situations. We have a very large workforce, all different types of skill mix. Our funding comes directly from taxes, around £116.4 billion for the NHS. In 2013, as I said, NHS England was formed, and it was part of the overall reform in the NHS from the Health and Social Care Act. And in October 2014, the NHS and other partners nationally set out the 5-year forward view to basically give the vision for services as to what we wanted to see different over the next 5 years, and is our strategy that we're working towards implementing and supporting locally to implement, that really seek to change a system that we've got to focus on the person being the centre of what we do. So that was in NHS England. Claire?
Hello, Martin, if you could just move to the next slide. Hello to everybody. My name's Claire Cordeaux. Delighted to be here. I'd like to add to what Jackie said, and thank you very much to Shari and Marsha for inviting us. Our role in this has really been to support the national program in the NHS with simulation. We're a simulation software company. We work all over the world, but we have a specialist health and social care team, and we combine our knowledge of healthcare with our software development to make sure that we produce simulation tools which are fit for purpose for solving current healthcare problems. And we've been proud to work with the NHS since around 2008 in doing some of that work. Which is the next slide, please.
Setting the scene for us, and I think what we recognise is actually these were global challenges that we were all facing, having spoken to colleagues from different countries. What we recognised and where the 5-year forward view came about, but equally what we've been grappling with for the last 10 years or more, is this understanding of long-term conditions increasing, but also the increase around multimorbidity, both physical and mental, with more and more people getting a combination of conditions. Aging population, but also recognising that age itself isn't necessarily the issue, but the aging process in deprived areas. We need to start thinking about aging 20 years before we do in some of our affluent areas. The expectations that we're all facing around wanting immediate access to services, getting treatment, and a real focus certainly has been in the NHS around continuing to try and cure things rather than accepting that actually a lot of things that people have wrong with now are about how we best manage people's support, how we best support people to manage their care to live as well as they possibly can. Our pressures, and equally again, I think globally, what we've ended up with is a real dependence on the system. We've got quite a paternalistic approach how we deliver care, and therefore, unsurprisingly, we make people dependent on us. Still a very big focus on the hospital and medic-centric care models. Workforce issues around recruitment and retention, ageing, again, of the workforce. Real fragmentation of care across health and our social care system, despite the fact that we all know that the independent system is so significant. And what we also have recognised through the Year of Care programme is the crisis curve, which I'll come back to shortly, but essentially tells us that we're too late quite often in identifying people needing support and being able to do the big changes that we need to. So if we can move to the next slide, please. This picture, I think, just illustrates the current situation that we're trying to transform in NHS, and it really is an example of the burden of treatment that we place on patients due to the system. So our example around a man who had heart failure, was being supported by a GP, a primary care physician, and actually turned down the offer of specialist support better manage his condition because he was basically fed up of lots of separate trips to see different specialists, have different appointments, diagnostic tests, etc. He calculated it was the equivalent of one full day every 2 weeks of his life was devoted just trying to access services that we were telling him he needed. A comment on Twitter this morning that I equally thought put it quite eloquently from a US doctor called Jim Rawson, who said it's hard to put the patient in the centre of healthcare if you're standing there yourself. And I think that equally resonates with some of the culture change that we're facing in the NHS about supporting practitioners to work differently, to think differently, to work in partnership with the patient so they do become the centre of the care that we're trying to provide. So the next slide, please. The activities that we have in the NHS and that we've been supporting through the programme that we'll talk about is set out. So really trying to transform an approach where patients and their caretakers are full partners in care. Looking at that whole person focus, as Marcia said at the beginning, not separating out mental health and physical health, so again interdependent, but also not focusing on individual diseases, but focusing on the person and what their needs are to live as best they can with whichever disease or diseases they have. Life course approach from diagnosis to death and recognising and supporting aging needs, helping to strengthen primary and community care. So out of hospital support is really proactive and preventative. Accepting the need to really focus on helping people age well, and we now are able to identify and diagnose frailty as a long-term condition and therefore manage it, rather than accepting frailty and inevitability of aging. Care models that I'm sure a lot of you will have heard about around the real switch to supporting providers to come together and away from being sucked into a hospital setting, and looking how we can work with secondary care colleagues, with hospital colleagues to provide more community approaches. Some of the key enablers around the technology we use, bring records and workforce. What we'll talk about in more detail with the programme that we've been focusing on is really understanding how we change what we buy in terms of services, with a particular focus on understanding population, understanding need, understanding the real outcomes that we get for what we buy and how we get best value out of those. What we have in the NHS, again, just to put a little bit of background, is still quite a complex approach to lots of individual contracts, episode payments for bits of care, lump sums and block contracts for other bits of care. So it's really difficult, as I said at the beginning, for providers to work collectively and collaboratively together, because we don't facilitate that with all the different contracting and funding arrangements that we have. So if you come to the next slide, please. One of the areas that we've learned through the programme, I wanted to put up front, and it's referencing back to what Marcia said, was about the language changing culture and being really important to set the tone from the outset. So we recognise that switching from using the term patient to person is really important. It moves from it being seen as a passive done-to approach to being a reactive done-with partnership. Switching from chronic disease to long-term conditions helps to move away from it being seen as a medical model that's needed to be delivered. Moving from lists of individual needs for whichever disease you've got to looking at whole person and what are the other factors impacting on the health and how they manage it, has been important to bring other partners into the process, such as having transport, etc. And moving from focusing on integrated care, which in the NHS certainly has tended to bring with it a focus on organisational restructure, to talking about coordinated care as the function, and helping providers to work together without needing to be one organisation. So the language that we've started to change to has been a really important learning point for us, to just help get the behaviours and reinforce those to make the differences that we're trying to implement. Move to the next slide, please. The Long-Term Conditions House of Care is our visual representation of the evidence-based framework that we're using to support the changes being made. And it sets out 4 key components that all need to be in place in order to really make this work. And in NHS, we suffer quite a lot from a disease called pilotitis. We try something, we don't really learn from it properly, we move on to the next thing. So things don't tend to be embedded very well, or there's individual pockets of good practice happening. As a result of thinking about this differently, what we've developed is this framework that sets out locally the things that you need to think about having in place that are going to make the biggest difference, and helping people work towards those depending on where they're starting from. The component at the bottom, focusing on commissioning, so for the NHS, about how we plan and pay for services, is where the Year of Care Commissioning Programme has focused its attention on. So how we change that mechanism in order to get engaged, informed patients and carers, to support health and care professionals working together, and to get great organisational and supporting processes to make the delivery models work as effectively as possible. On to the next slide, please. The outcomes that we're working towards are based on the Triple Aim and are both proxy outcome measures as well as longitudinal ones, recognising that we need to be able to measure shift in how we're delivering care as well as the ultimate outcomes in differences in clinical, experiential and value for money metrics that we're trying to see change. So looking at metrics like transitions of care, and we'll come on to the recovery, reablement and rehabilitation element of the programme that helps us look at that shortly, looking at what shifts we're seeing in terms of hospital-based care to residential care or to home-based care, and looking at what shifts we've got around experience of care, but also quality of life and death for people. Move to the next slide, please. We don't have, and as I said at the beginning, we don't have all the answers here, just lots of learning to share. We don't have everything in place in any one area yet, but what we do is people working towards the model, and outcomes and benefits starting to be demonstrated, such as the ones on the slide. So we know that, for instance, training some clinical workforce in how to do health coaching can free up capacity in the workforce to be able to work differently and to support more people. But also know that coaching of people and giving good care coordination can reduce the need for acute care and for crises occurring. We know that supporting people to really understand whatever diseases they have, and for in particular their medication, improves adherence. We have examples in areas like cystic fibrosis. And we know that the frailty agenda and managing that better, we could save between 20 and 30% of hospital admissions in older people. Move to the next slide, please. The first question we sought to answer through the Long-Term Conditions Year of Care programme was really understanding what the population was like, trying to get to grips with who were the people that needed support, what level of risk they had and why, predicting need and the services that needed to be put in place to really support outcomes that we were trying to achieve. So move on to the next slide, please. So the work we've done over the past 4 years has given us a huge amount of information that we didn't have before, which I'll share with you. It has been based on sites that we've been working with in the different areas, providing lots of local data, as well as looking at national data that's been coming on board, really get a granular understanding of the different types of need that we're seeing now. So now know, for instance, we have at least a third of our population with more than one long-term condition. We know 16 million have one and 10 have more than 2 or more. We also know that with the ability to diagnose frailty, we can predict that there's 1 million people with frailty at different levels of severity, and we can now predict that in terms of people in the last 12 months of life, there are 500,000 every year. Next slide, please. So in terms of research, on the basis of those different stats that we've started to come out with, it's really helping to illustrate locally as well as nationally the need to focus on the person rather than each individual disease, because the system that just can't cope with that now, and it won't be able to cope with that in the future. And the following slide illustrates at a local level the different comorbidities that are found to be most common. Moving on to the next slide, please. Research was based on some done in Scotland quite a few years ago, and it's been replicated in the local areas on the programme with similar results. And it really just demonstrates the level of multimorbidity for different conditions that can be incredibly helpful, and we found particularly with specialists helpful for them to understand that that person who sat in front of them with potentially diabetes is more likely to have a number of other things wrong with them, but equally as a person and looking at their whole person needs, it could be the social issues that's impacting on the management of diabetes. So data that we're seeing as a result of the programme is really helping to get clinicians on board with thinking differently about how to support person-centred care. Move to the next slide, please. What we also found is some really helpful information around the number of hours that people on average with long-term conditions actually spend with a health professional. Only on average 4 hours per year. So by default, the rest of the time people are self-managing, but what we're not doing is supporting that constructively and wondering why then people end up needing help. 33% of our consultations in primary care, so with a primary care physician, are for people with multiple long-term conditions, and those repeated appointments, because people are coming for individual symptoms or for individual diseases because of the way we've built the system in the NHS. And we know that only 3.2% of people with long-term conditions actually have a care plan, despite knowing that a good jointly agreed care plan can support much better outcomes and reduce resource utilisation. The next slide, please. We've found that 50% of our total emergency bed days are for the over 75s. But what I'd flag here is that does depend on the levels of deprivation. So in some areas that is a lot younger. We know that in care home beds, care homes, that 4% of our over 65s are residents, but they to 14% of our total emergency admissions give us a really good indication that we're not doing good enough to support people in care homes. And a quarter of our hospital beds at any one time are occupied by someone who's dying, probably doesn't want to be there and probably doesn't need to be there if we got care in the community better. And we know that with the ability to diagnose frailty, that we can see it causes a threefold increase in cost. So a real driver for us to be able to manage frailty better as a long-term condition. Moving on to the next slide, please. What we also looked at is using risk stratification tools to understand how best to predict need in the most timely way. And in the NHS in England, there's lots of different tools that are used, but the different tools and the different questions they ask therefore give you different answers. So depending on which cohort people are wanting to support has led us to understand which particular risk stratification approach serves best to answer those questions. We've also recognised and I guess intuitively knew, but the work has supported, is the IT tools are great, have to be supplemented with clinical intelligence. So the LDT discussions that we use in the NHS to look at data and understand what actually that means in terms of the patients at the end of it has been really important in understanding then who would benefit from this. The next slide, please. The risk profiling work has also led us to understand the crisis curve that I mentioned earlier and identify this better. So the crisis curve is essentially where people with the most complex care demonstrate a peak at which they go into crisis and cost a lot of money, because they need more non-elective care. But after that crisis curve, their health then stabilises. Also being able to identify that a large number of people with most complex care proportion die within the 12 months. So with the ability to understand both of those, having looked at risk stratification tools and approaches to segmenting the population, we identified that using multi-morbidity as the approach to select the cohort and look at how we type interventions is the most stable method. Risk scores tend to historical needs rather than future needs. And if we just move on to the next slide, the graph just demonstrates a visual representation of that crisis curve. We're trying to do through tracking, what we've been doing through the programme and tracking patient data over 3 to 5 years in local areas, is to identify people before they hit the crisis curve and therefore be able to support and better target the interventions in a more timely way to enable better outcomes for people, but also less resource utilisation. Move to the next slide, please. The element we've also analysed is the impact on carers and the impact on the system and the patient when carers' health fails as well, or informal caretakers. We know that nearly 1 in 2 of carers in England, when they've fallen ill, have not had support and have had to continue caring. And we know that 1 in 5 get no practical support with caring at all from us in the NHS or in the social care system. But we also know that 1 in 9 have needed emergency care themselves, which has meant a double impact on the system, because the person that they're caring for has then needed to go into emergency care as a result. So recognising that we need to do more to support carers is important, both from the health of the care perspective, but also the people they are caring for. To the next slide, please. And to finish, in terms of understanding the population, the focus that we've certainly in the NHS on reducing mortality has been fantastic and really positive in terms of all of our results, but unfortunately we haven't done much very well is helping people live longer well. We've done some ethnographic work with Ipsos Mori, and there's lots of resources and data available on this to understand the qualitative impact of what living with complex needs and multi-morbidity and not getting the right support actually means for people. We know from the patient survey that we do on a national basis that the larger the number of comorbidities, the lower the quality of life, and again that's linked to deprivation. And we know that we've got increasing evidence on overtreatment and indeed harm. Our evidence-based guidelines are focused on research on the under 65 and with single conditions. So we're supporting the approach of evidence-led guidelines and evidence-led medicine rather than evidence-based, so that we don't have to ask clinicians to rigidly stick to guidelines that don't necessarily meet the needs of the people they're trying to support. And then finally, what we've also recognised is that social isolation and loneliness is a risk factor for mortality, but it's also a factor that needs to be thought about almost as another long-term condition, as a comorbidity. The impact on people and services of social isolation is being seen to be almost as great as having another long-term condition. So for the next slide, the second question we then asked ourselves, and the third indeed, after understanding the population, was what we could do differently if we had a capitated budget to look at how we bought care, but also therefore the delivery models that could be developed to support individual needs rather than having the separate organisational approach that we've been having so far. So moving to the next slide, we were able to look at the service bundle that makes most sense to include within a capitated budget and therefore delivery model, because of understanding the population that we the population and the different cohorts that need support. And I'm able to identify the activity and cost of all of those different services within the bundle to be able to look at then what a total budget could look like to help people locally redesign the actual care delivery models in each of the areas. It's been a journey, and it's a phased process based on how quickly people locally can make change. So for some within the first bubble, include within capitated budget, those are the services within this approach that everybody has been able to include. The next bubble include when possible have been variable in terms of inclusion, depending on where locally they've already been, both in understanding the data, but also in having the relationships to be able to bring those services into the total approach. And the last bubble, the high-cost drugs, critical care, etc., are the areas that the link we found suggests that they should be excluded from capitated budgets anyway, because of the risk, the risk to managing a budget with such significant variation in cost. So if we move the next slide, please. So as a result of all of that, the teams have then been able to think about, as I said, what different delivery models make most sense. Thinking about the services that are out of the budget but still need to be part of a care approach, and the population needs that we're wanting to support differently. And there are lots of similarities within the delivery models, but there are also some differences depending on geography, types of population. Similarities have been around care planning and shared care records, self-management as a core component of the delivery model, and ensuring that sees a credible intervention in its own right, rather than certainly in the NHS it's been perceived as a band of care by a lot of people. They're just left in with it. Care coordination to ensure that people get the right care at the right time, rather than as the example at the beginning of the discussion with the patient who had 54 different visits in the period of time, things where we can once rather than have to replicate everything. Lots of work on community multidisciplinary teams, focusing around our primary care physician as homes and medical and social care homes, and look at wider neighbourhood support, which includes specialist practitioners and therapists, but also community groups, voluntary sector, and wider support even from public services such as the fire and rescue, police, etc., who are offering support to health to be part of that wider community workforce. The reablement and rehabilitation service, Claire will come back to, but essentially has been our approach at looking at when people don't need to be in an acute bed anymore and what sort of support they need to get back to as much independence as we can do. And care navigators are a new role for us in the NHS that are just starting to emerge, which has been a role pretty non-clinical and mainly based on volunteers and charity services, giving peer support, advocacy, and just helping those people when they're in need be able to navigate, as the name would suggest, the system to get the right support at the right time. Next slide, please. The next stage of the work was to look at then the capitated budget and how to develop those, and emerging delivery models and the service bundles that gave us the total pool, the total budget to draw on, helped the local teams and us nationally really understand how a capitated budget could work, the different levels within need for the cohort of patients, whether it be someone who's quite simple and may have one or two long-term conditions, or whether that be somebody who's much more complex and has 5 or 6 long-term conditions. And that's helping the teams to plan the budgets with the providers, but also has enabled the local areas to do a lot of the responsibility around the delivery model to the providers to be able to work much more innovatively together, because we're having the individual approach to budgets, contracts, and performance metrics. Running from the capitated budgets around risk, so poor data quality, pretty obvious. If it's quality, then estimates around how to include it could be really badly implemented. So the areas in the not yet bundle for some of the local teams have been because they've got poor data quality, and improving that has been a key action for them. Some changes in care and the needs over time have meant that people have come in and out. So for us in the NHS, we have continuing health care, which is when you have very high specific needs, very high cost services, have tended to take the risk into, take them into too high risks for the budget as a capitated budget. And the potential for double payment has been identified again as a risk both for providers and purchasers, to really make sure that we can identify, using the IT systems, the cohorts that are being supported in this way, budget therefore that's attributed to that, and how we ensure that providers are paid appropriately. Changes in the cohort also have been identified as needing to be managed, just to ensure that the numbers don't vary too significantly with people dying or leaving, or new patients coming into the cohort. Understanding the needs of individuals as they move through their life course, and where they may shift between the groupings of multiple morbidities. Our local areas are going to look at increasing the capitated budget over time as people's needs do change, but also they look at the impact of the different way of working in terms of getting better value for the services. So they can also look at doing more for the same amount of money, or doing more for more people for the same amount of money. So lots of different things that the teams have been thinking about in terms of setting a capitated budget, and then understanding how to manage that. On to the next slide. And finally, looking at the contracts and understanding, again, where people are at with what they have felt has been appropriate. So another journey for our teams around the relationships locally have led them to identify contracting models for this, where they had really strong relationships. They have often gone straight to a prime provider contract, or even started to develop accountable care organisations, replicating the work that you've been doing in the US. But for others, it's been a much more gentle approach, with people starting to develop compacts, agreements where they'll work together as a first go at getting good relationships through the different provider organisations. The monitoring, as I said earlier, looking at that triple aim, but looking at that triple aim across the whole provider landscape rather than by individual organisation. So individual organisations will still have specific and are still being asked to achieve specific metrics based on their own particular contribution to this, but the actual performance of the approach, we're looking at outcomes that are about people, populations, not the individual providers. And moving on to the last slide for me, the graph that I think just gives us, again, the learning and the summary for the approach. The population analysis really identified for us that multimorbidity was the key thing to focus on, that it was the way to more stably identify population needs and risks, and it also has been the thing that's driving costs. We've been able to then understand the services and the budget, support the design of the services, and manage that capitated budget with different contracting models that are based on relationships and helping people evolve and develop the approach based on where they start from. So the programme over the 4 years, as I said at the start, has been experiential. It's been a journey for us nationally and for the teams locally to understand how to change the system of buying and providing care and the relationships between purchasers and providers to focus on improving the outcomes for people with long-term conditions to the person-centred care rather than individual organisational services. Reflecting back again, the key thing for us throughout the whole programme has been to use simulation modelling to really understand at a national and a local level what impact any of those bits of the programme is going to have, so it's supported local teams being able to implement changes in a way that's been much more manageable. And I'll hand over to Claire.
Thanks so much, Jackie, for that. And it's been a privilege to work alongside the national team developing simulation. If we could just go to the next slide, please, to both to inform the process, but also to try and crystallise it, if you like, to capture it, to enable this to be disseminated across a far wider population. The work that Jackie's referred to has been 8 different sites at different times have been contributing to our developing understanding of what happens if you essentially flip healthcare on its head and look at the person rather than the disease, and what the key issues are. Now, everybody in the country is wanting to try and do this. And so how can you disseminate that? You can disseminate through stories, through narrative, through case studies, but actually the complexity of some of those stories and the organisations, all of the services that the people are using is quite hard to capture. And when you're looking in your local area at how you want to implement this in your region for your population, having a simulation model which allows you to use same parameters as the early implementer sites, but overlay that with your population can really help with the dissemination, and that's really what we've been doing. So if we go to the next slide, please. So simulation, when I'm talking about simulation here, I'm talking about computer simulation. I'm talking about modelling the system as currently is in a computer, understanding how people use services in particular groups, and then being able to ask on that computer how this will impact if we make a change, so that you're making the change in a virtual environment and testing the impacts before you implement reality. And what we're finding is that kind of technique is a very good way of allowing people to have discussions with the different providers that Jackie was talking about, liaising with the different stakeholders, allowing people to understand the impact of the change and really take some of the risk out of that implementation. So the point is to simulate what's going on at the moment, to ask some what-if questions across your whole system, include the impact of demographics and how patient journeys are going to change, and then understand that change scenario with your baseline. Go on to the next slide, please. So in case of the whole program, and I'm going to show you 2 simulations. The first one is really looking at that overarching program where we're trying to identify the patients and the people that are most likely to need these sorts of new interventions based on whatever risk stratification that a locality will use. And in this particular case, we've tried to understand this as the person at the centre of the system, having probabilities of accessing different services as part of the system. So in this particular image, you can see somebody who's reasonably healthy, but who maybe has 1 or 2 long-term conditions, has a 39% probability of using the emergency department and then 22% probability of having an admission. And through the early implementer sites, what we did was we looked at the different cohorts of patients that people were modelling and were testing, and we found that actually they did fall into these different groups if you looked at a risk stratification methodology overlaid with the number of long-term conditions. So this is somebody who's reasonably healthy, and if you just go on to the next slide, we see a stage where this person has become more frail, needs more support, and therefore the likelihood of them needing those different services has changed. Now, as Jacquie said, whilst when you start your new model of care, you have a finite population, you know who they are, you know they're changing services and using services, and you know the new model of care that you want to implement. But obviously, if you're running this forward over a number of years, and it takes a number of years to implement some of these new models of care, and you want to take into account your population change, you've also got to take into account the fact that the patients will transition. So somebody who has 2 long-term conditions now may have 3 or 4 in 3 years' time. And also people will leave that cohort because they die. You'll have more people joining the cohort from the rest of the population. So that transitioning needs to be reflected somehow in the model. So within our simulation model, we have these different groups of patients, but we also have them transitioning between those different states over the years that it runs through. Next slide, please. Thank you. So this is a model of the simulation that people have been using, and you can see that within the graphic there we have 4 groups, up to 4 groups of patients that people can model. Now, some people have chosen to use different models of care. In this case, they've been looking at an extensivist cohort and a more enhanced primary care cohort, and I'll come on to what we mean by that. In other areas, they've looked at patients who are in care homes. In other areas, they've chosen them by number of long-term conditions. But the process is the same. You have patients who are likely to need different sorts of services with a different kind of frequency, and might go to those services more than once. And those will be in hospital, but they will also be in the community. And if we go to the next slide, I'll show you a little bit more about what that means. So we're running the simulation. We're looking at, we've actually pre-populated it with demographics for the NHS England populations that are likely to use it, to take some of the pain out of trying to find those, and put in projections up to 10 years so that data is already there. And then the local sites can select up to those 4 patient groups by what methodologies they choose. Probably that will be a proportion of the total population, so you can link, therefore, the population change with the proportion of patients likely to be in those 4 target groups. And we also include incidence as a way of understanding how those numbers are going to change year on year. And then what we look at is how those individual people use services in a typical year. So we look at the probability of acute service use. In hospital, we also look at the probability of community and social care if people have access to that data. We look at the cost by service, and we encourage people to run the scenario forward for 10 years. So if we do nothing, this is what's likely to happen. And then the scenario that you can introduce at that point is what happens if we put in a person-centred care intervention, a new model of care, a single access point, whatever the models of care, and Jacquie referred to them earlier, what happens if we introduce that? What's the likely impact on our hospital services? What's the likely activity we expect? Is an individual person going to use that service 10 times in a year or only once, or some sort of distribution across that spectrum? And what's the cost? So that you can think about, you can run the model and can understand the financial impact as well as the capacity impact. And then, of course, one of the other complexities in this is that patients are not likely to all take up the service on day one, and also localities might not want to offer that services to all patients. They might start a neighbourhood at a time. And one of the things we've learned is that not all people will want to take up that new service. So that the whole intervention needs to be phased over time in order to give you a sense of where the investment needs to be at a strategic level, and also across organisations and within services. So that's the sort of overview of the simulation. If we just move to the next slide, please. And the sorts of results that you get from that is then understanding, well, how many patients in each group are we likely to see each year? How is that going to change? What's the average cost per patient? So if we were setting a capitated budget for an individual, you can start to see the sort of the cost bands that they would start to fit into. And then if you wanted to compare costs, so one of the things people wanted to look at is, well, what's my actual cost of providing this type of service against my revenue that I'm expecting, and how does that compare with the tariff, the budget per patient that I'm going to put in place? So from whatever angle you wanted to have a look at that cost information, depending on what kind of healthcare provider you were and where you were standing, you could start to see those sorts of results. And the next slide also shows the individual services. So in this particular case, if we wanted to look at people using services typically, what does it mean for the emergency department? So in this case, you can then see drill down the activity in each group in the emergency department, the resource that's required to deliver that activity, how many patients, again, in the overall cohort, so you can measure that, and what are the costs. And this sort of data was the data that people really needed to be able to make decisions about what does this new model of care, this new way of delivering services actually mean for not just for the patient or the person, but also for the my particular organisation and the services we provide. And as Jacquie said, it enabled some of that local dialogue to take place to understand how to manage budgets, how to create incentives for organisations to be part of this overall system when you're looking at the whole service and an individual patient. Next slide, please. I just wanted to run through a quick example. So this particular example was of extensivist care and enhanced primary care, and this was a locality where they used a stratification tool, and they'd seen that 1.6% of the population was assessed as in need of extensive support. That sort of model is about having your care coordinated by a clinician for all services, regardless of where they are, hospital and community. And it includes regular contact with a health and wellbeing support worker to make sure that the person is accessing the services that they need for their conditions, and that the patient is informed, is activated, is managing their care with their carer as much as they can. And the evidence is that reduces hospital and emergency and also planned visits. They also defined a further 36% of the population that they thought should be receiving an enhanced primary care, managed by their primary care physician, but with a lighter touch than the extensivist care model, but still with some of those features. Next slide, please. So I ran through that simulation and looked at the baseline results and against both of those models of care. And one of the interesting things they found was that when they looked at the overall cost of the care, they could see that, in fact, their new scenario was going to cost more than their baseline, which was not really what they'd hoped. And if you could go to the next slide. You can see that when they looked at only that 1.6% of the population, they could see that over time, as they phased in the new intervention, they started to see a real return on investment. So you can see that purple line at the bottom there on the baseline versus the scenario is now producing fewer costs. Now, that's not the only measure of this particular model of care, but in terms of reassuring the system that the extensivist care model would be relatively risk-free when you're looking at the financial side of implementation, that gave them the confidence to go ahead and implement. Please. The similar results are being used to to talk with stakeholders across different organisations about what the impact of that new model would be, and to help understand what level of budget would need to be set for each patient type, what are the cost bandings to help with financial planning around that, and what would be the impact financially, and also the capacity required to bring in a new model of person-centred care. Next, please. To show you the second simulation as well, which is looking at this this recovery, reablement and rehabilitation service that Jacquie was talking about. This is known as the RRR model. And what it's particularly looking at is that point when somebody doesn't need medical care in the hospital anymore and needs to move to rehabilitation. Now, one of the key issues for this is that when your data for a typical length of stay of somebody in that group, it's very hard to define the point at which that person no longer needed to be under medical care and when they needed to move to recovery. And one of the things that simulation is quite useful for is when you have no data to historical data to model, because it's a completely new thing and you haven't looked at your current data in that way. And so what we did was we looked at that acute phase and we asked a number of clinicians how long they thought that acute phase was, and asked them to give some distributions around that. And then we looked at the point when the decision to discharge would be, and gave some time for patients to transition to that point. And then the point of discharge, which is when they would need an alternative facility for rehabilitation, whether that's in the same hospital or in the community hospital or at home with support. Next slide, please. The audits identified very clearly that point, acute phase, that you would need to go into RRR phase. And the suggestion was that there should be a different payment at that point, and what would be the impact of having that different payment, and also what capacity would we need. So to the next slide, I think at this point we're going to be able to show a live simulation. The point from this, the lesson was that we need to change the payment at the point when the patient's needs change, just when organisation changes. So hopefully up on your screen in a minute you'll see the live simulation. There we are. What you can see here is we've built this to look at different patient types. So if, I think I should get the controls at the moment in a minute to be able to share. So on this simulation, we've got a means of defining the different patient types in the simulation, and we've divided these into complex and non-complex groups, and also their probabilities of going home with support, go to the community hospital, or having their recovery in the hospital. And it means people can change this to test out their local assumptions. In a particular case, we've divided these into 4 individual types, disease types, that people can put in their own patient cohorts, depending if they're wanting to model. And then you put in the average weekly arrivals for each disease area. Now, allowed to do in the simulation is to put in their own assumptions based on what their clinicians are saying about what the typical length of stay would be at each phase in that pathway until you get to that discharge phase into that recovery rehabilitation phase. And then also there's a chance of death in acute phase as well. So given there's very little data to split up your length of stay, it's a discussion that you have with your clinicians in order to test out what that might mean, so you can then look at where the costs are and what capacity you need. You can also look at the number of beds available. So I'm just going to change this to 73 beds, 100 acute beds, run through the simulation. So you see the clock going, moving forward there. This is virtual time taking place. And you see the acute beds and the recovery beds being used as a result of what we put into our simulation. And if I go through a little bit quicker, you see there's a point in time when the recovery beds are blocked because we haven't got any capacity. And if to the end, you start to see those overall figures. So for you, just very quickly, the results. You see how many patients were in each state, the average length of stay, what the cost was, the average cost per patient. And it's been a means of helping people to understand how to model their bed capacity and their rehabilitation bed capacity required if you implemented part of this new model of care, which is trying to move people into a more appropriate care and they no longer need a hospital bed. You can see here also how your beds are being used, and in this case it's 100%, so we haven't got enough of those, and you can start to experiment with this in order to help make decisions. We've actually made this simulation available to you, so you can test it yourself, and we'll give you the links a little bit later on. So if we could go back to the slides now. And you skip to the next slide, and the one for that. So just to summarise, really, the benefits of using simulation, particularly when it's a new model of care, we've never done this before, is you can really test other scenarios before you implement. These are big, complex changes in a complex system, and of course there's no harm to patients by testing something in a virtual environment through a simulation. But it's also a very good way of disseminating practice that some of the early implementers have had and sharing those models of care in a way that that really supplements the narrative and the case studies. It supports people's visions where we've got no historical data, and people are using it to help formulate what their exact model of care should be. So we've been, with some of the sites we've been working with recently, we've seen them initially that somebody would probably have 12 visits from health and care, a wellbeing support worker, whereas in fact there's probably only 3 visits are required. So some of these things you don't know, and you can use it on an ongoing basis to test. So once you implement, you can look at your results against what you'd predicted. You can then change your simulation, so you can use it to help monitor your performance. Next, please. So I'm just going to hand back to Jacquie to talk about the national rollout and resources.
Can you hear me?
Yes.
Great. So just to briefly finish off, in terms of what we're doing, the national programme with the 4-year experimental phase and the early implementer sites just finished this March. We've got an implementation guide with the learning from the sites about to be published and a wealth of case studies. But alongside the early implementers, as Claire and Marcia mentioned earlier, we've also had a community called Fast Followers who've been taking the learning as we've gone and starting to implement it themselves. So we're starting to see this approach and the learning from this approach being rolled out in lots of other areas, and continuing to support people to learn from each other throughout the process. The next slide has the link to all of our programme resources that are available. As I said, lots of case studies and resources, but also the implementation guide. The slide has the link to simulation models that Claire has demonstrated. And the following slide is our contact details for anyone who's interested following the webinar to get any more detail. And with that, I would just like to say thank you very much on behalf of Claire and myself, and I'm very happy to take questions.
Thank you. This is Marcia. Sherry had to leave for another meeting, and she wanted to thank you again for taking time out from just your experience and share the simulation, the role of simulation with us. She had a question. She wanted to know, What is the source to identify frailty in the population? Is that different people with functional limitations that require adaptive or supportive services? And what services are most helpful in averting hospitalization, et cetera, population?
The frailty, the diagnosis for frailty that we're using is called the Frailty Index, and it's I think 6 different components that essentially aggregate up to identifying frailty in someone. So things like the Gates test that I don't know if you use over in the States. Functional ability is one. Mobility issues. There's 5 or 6 different components, but I can get more information on that. In fact, I think in links for the resources that's in the slide pack, that is part of the resources that are available. And we've also got a frailty pathway that is published, and it sets out at different points of severity, both in terms of preventing frailty, what sort of things you can do. We have a healthy aging guide that's very much focused about helping older people to look after their health and well-being and to prevent frailty, but also what clinically we can be doing. And then at low, medium and severe levels of frailty, what are the best interventions? And severe frailty is a really good predictor of being in the last 12 months of life. So what we can also do is link then people with severe frailty into making sure they get good end-of-life care. Is there a second question, Marsha? Sorry.
The question was like, what services are most helpful in averting hospitalization?
Yeah, in that particular cohort.
Yes.
So it depends what level of severity of frailty people have, but generally low-level frailty is more about self-management support, so different interventions depending on what people feel is right for them. That might be accessing community groups, going to exercise classes or dance classes, for instance. It might be in the medium level of frailty, about falls assessments and ensuring the right equipment goes into homes, and in the high level of severity, as I said, that tends to be actually about good end-of-life care and putting in good advanced care plans to stop people ending up being whisked into hospital as an emergency.
Thank you.
A question from the audience. Has the intervention for aspects like the extensivist been handed to younger medically complex patients?
Great question. So for this particular program and the examples that we've got, not yet, because the cohort that we've been particularly looking at to develop the approach has been about multi-morbidity. By definition, it's tended to be older people. But the approach is also being, the learning that we've had and the approach is also being used in the integrated personalised commissioning program that is being run at the moment. It's in the first year, and that is looking at different cohorts like learning disabilities and children with complex needs, including educational needs. Definite adaptability in terms of the model for different cohorts is rounded. Actually, it's about understanding your population and modelling and etc. So it can completely be replicated.
At this time, we will unmute the lines for questions. We ask that if you aren't asking a question to please mute your line to reduce background noise. You can also ask questions through the question and answer WebEx feature. Please feel free to speak up.
To ask a question. One of the things we're very interested in is whether this resonates with a US view of healthcare. It's been something that's been very radical for us in NHS England. wonder how far we are apart when we're thinking about these sorts of ways of working with people.
Efforts are very similar to ours. And actually, I had a question. Can you hear me?
Yeah.
Oh, okay. I have a question about. I was interested in learning a little more about when you don't have any full historical data, and talking about the transition of patients. In some of our programs, there's what's called churning, when patients go, people move in and out of care, and you're trying to implement a quality improvement program and provide services. So could you talk about a little bit more about how you would anticipate, or how there's the development of a model when you have any historical data? I'm thinking about our efforts for marketplace market came up a lot.
So when we've been looking at some of the areas where there isn't very much data, I'll just pick up from the station point first, and then perhaps Jackie can supplement. But we tend to, the most important data we've found is to identify type of population, to try and get a sense of how many people in the population fall into a particular group. And sometimes you can't get that from hospital data. You can sometimes get it from these prevalence data. So sometimes secondary sources, peer-reviewed journals, epidemiology can give you a good sense of what you might be looking at in your population if people were to present, which at least gives you something to go on. And then from that, when we're modelling, we look at the typical process that those people would tend to follow, and mostly, even if it's not laid out in any formal way, just talking to clinicians, talking to people who are providing the service, they will know a lot about their bit of the service, and you can very often work out what happens next by interviewing the next group of people, and making sure that you've also included the sort of biological, if you like, pathway. So you've looked at the clinical pathway that the condition follows. So, if you have a mild form of dementia, then that's likely to progress to a moderate form of dementia within perhaps 3 to 8 years if you don't manage to arrest it, and there's a likelihood of dying during that period. And all of that data is usually available through peer-reviewed journals. What we tend to do is to build a simulation a bit like that, based on whatever data we can find that's been published, and then work with a local site to validate the model with their local data, so just to change the points of it. And then even if you don't get it completely correct, you can start asking your what-ifs, because with a simulation, of it is to help people learn about their system. You can do some very clever modelling, which is absolutely correct, but only the modeller really understands what the system looks like. The real value of it is helping the people who are running and working in the healthcare system to understand what it's like, and then what the impact would be of changing it. And the important thing is the comparative use. The baseline, or something that looks like as much of the baseline as we know it to be, against what we think might happen if we make that change based on our own baseline. And if you don't know what's going on in your system, actually you don't have anything else to go on. You don't have that baseline anyway. So using the simulation can be very helpful in helping you get a grip of what is likely to be going on, and also identify the areas where you might want to do an audit to get better data. Jacquie, did you want to say anything?
The other point, I think, and I only very briefly touched on it, it could be a whole webinar presentation itself, but has been the work that sites have been doing to integrate data sets. So one of the things we recognise is actually there is quite data that we don't use, and we ask a lot of providers to provide data that is never used. Why are we asking for it? But some of the information that we do want, we're not asking. So what we're looking looking at is getting a real understanding of what's the totality of data that is available. And as Claire's mentioned, it's looking at lots of different sources. How do local areas pull that together into integrated data sets, really help them focus their attention on the right things, but it helps them locally understand where some of the data quality issues are and gaps in data. And then nationally, what we're looking at is where there are gaps in nationally mandated data sets that we could improve as a result. So it's a two-way process of continuing to understand, bring together and identify improvements that need to be made in data.
We have another question. Have you implemented any financial reward systems for improvement in outcomes, pay, or performance?
So in the different sites, they've been approaching the sort of risk-reward side of this in different ways. And again, it's gone back to relationships. So the different incentives and mechanisms, I think, reflect the different maturity of the relationships that people have got. What some are doing, for instance, is looking at the purchaser, the buyer, underwriting the risk of the budget for the first couple of years to enable the providers to be innovative, to test things out without the fear of failure holding them back, etc. So that's one approach that some sites used, and in others they're looking at pooling together the different incentive schemes that different providers have got so that they're all aligned. So where a hospital has an incentive scheme aligns with the incentive scheme for a community provider. So again, it's supporting all of those individual providers to work to the same metrics, the same outcomes that we're after. Different approaches depending on how good the relationships are and how quickly people can move.
Everyone's unmuted, so if you have a question, please feel free to speak up, or you can also type a question to us over the Q&A feature. We just received a question. What is NHS's plan to evaluate the model after implementing? What research design does NHS use?
Oh, great question. So we've done evaluation as we've gone in terms of the national sort of program. I did a first-year evaluation with York University which gave us the understanding around the multi-morbidity being the most stable approach to identifying this particular cohort, and various other things that came out of that, and that report, I think, is again on the link with the resource I showed earlier, or that Martin earlier. But predominantly what we have been doing is working with the local teams to help them evaluate the approaches they've gone along. So looking at evaluating how the service has been developed with patients, so looking at how they've been using their feedback and experience as part of the process, how they've evaluated the development and staff involvement and satisfaction, and then the outcomes that I showed at the very beginning, how as the model starts to be implemented, those metrics can demonstrate the changes that we're after, which were captured both locally and those metrics, most of them are also available nationally. So it will be an ongoing piece of work both for us at a national level, but also for the local teams to be continuing to evaluate it as part of their approach to how they plan and plan and buy services going forward.
Question: how do you calculate return on investment for these simulation models?
So the example I showed you, we ran a baseline simulation for patient groups within an overall population, and that's looking at is how many patients in each individual group, what services are they likely to use, what's the distribution of use of that, what's the frequency, and how those patients year on year. So do they move different groups? Do new patients join the group? Do ones leave? So all of that is the baseline, and we calculate that both in terms of capacity and cost. And the results I showed you was just on the cost. And then we follow the same process, but you're able to put in your new model of care. So one of the things that the simulation asks you is what proportion of patients do you think would receive this new model of care? What is the new model of care? Who's delivering it? How many times would they be expected to see an individual patient? Would that be a phone call? Would that be a visit? How long would they spend with each patient? How long would the kind of period of care last? Would it be 6 months? Would it be 9 months? Would it be 5 weeks? Is it some sort of distribution between the two? And then what's the unit cost of each of those contacts with that service? Because mostly these are community services or care services, or they're out of hospital, so we're not particularly looking at length of stay. And then, of course, all the patients that don't use that service use the baseline, and we would expect to see a reduced frequency of attendance at the emergency department, and then onward admissions as a result, and have got pilot data that we can use to put that in. And so we run that through in the same way, and then compare the two, and then look at the overall difference in cost. Hope it makes sense.
We received another question. Does NHS have or uses more real-time modeling or alerts in the EMR to predict things like potential for readmissions, or to identify potential issues around utilization at the point of care?
Well, it's a really interesting question. We've just been going through the most recent iteration of the overall simulation work with a number of sites, looking at individual person-centered care models, and it's about to be launched. These simulations are very iterative because we keep learning more things about how the system works when you make these changes. And one of the things that people have said is, how can we can understand what component, this gives us confidence in making a decision, but how can we use this iteratively? How can we load it up with real-time data from our electronic health record, so that we get information about what's likely to be needed with some notice, so that you at a high-level planning level, you can look at what's likely to happen in the next quarter or the next year. But the other thing they're wanting to start to look at is how could we get this kind of information to clinicians about individual patients that they're seeing. So that's been a very exciting request, really, to have come out of that work, and Jackie and I have been discussing how we might be able to make some headway on that. So I don't know what the situation is from the questioners there, but if those are the questions that you're asking locally as well, I'd love to hear how you're doing it, because that's certainly been a request from our side.
Our last question, besides the NHS, are there any other healthcare organizations that are implementing similar interventions concurrently on the same group of patients? If so, how does NHS identify the independent effects of this intervention on health outcomes?
So the looking at is locally a whole system change, and so for us that is NHS in terms of hospital, primary care practitioners, community services, social care, outside the NHS, but also any voluntary organisations that are purchased to provide healthcare services, etc. So what the approach is aimed to do is to not separate out either the purchasers or the providers or therefore the delivery model, so that we can get all of those interdependencies that we know occur supported by providers in all of those different arenas working together, so we don't have to look at individual impact changes. We look at the overall changes that we're trying to make, and as a new way of working, whether it's going in the right direction or not. So it's less about understanding individual organisational impact and more about how working in a different way altogether is changing the outcomes for for people, but also for the service utilisation and cost of and budget that we've got. I think that's the answer to that question, unless I misunderstood the question.
We'll come to the end of the webinar. Thank you, Claire and Jackie. I would like to remind everyone that an email with information about where you can find the slides and recording of this presentation will be sent out soon. For questions or suggestions for topics and future presenters, please email us at mmssupport@battelle.org. And with that, we want to take this opportunity to thank everyone for attending today's presentation. Thank you and goodbye.